So it gives me great pleasure now to introduce Dr. Albert Power, who is a consultant nephrologist, a kidney doctor at Southmead Hospital in Bristol. So Albert, if I will now stop sharing, and I think you are going to share.
That's right, yep.
Your
Thank you.
screen.
Thank you very much. Let me try and get this going. So I'm going to talk about the basics of PKD. I don't intend to go into enormous amounts of detail. I just want to provide an overview of the condition, provide talking points maybe, and just fill in the knowledge gaps. One health warning, there is just the one slide, the one gory slide of kidneys taken from someone with PKD. I won't linger on it too long, as I appreciate that our tolerance of goriness can vary. Okay, I'll try not to make it too technical as well. Most of the questions I'll do my best to answer in the interval, but if they clearly dovetail into the slide I'm talking about, I may try and answer them there and then. I'll try and move this on. Apologies. So PKD is a genetic condition. Okay, so in other words, it's an inherited condition that arises due to changes in our genes, and it's the commonest genetic cause of persisting kidney impairment, of chronic kidney disease. And as we all know by now, our genes make us pretty much who we are. Genes are sort of information pieces, if you like, that are then used to generate structures within our body, proteins that then carry out the work that we do. And lots of these genes are all wound up tightly within our DNA that moves through all our cells in bunches called chromosomes. So in terms of PKD, there are two classical forms that have been described now for many years based on their pattern of inheritance. And Tess has already talked about what we're going to be referring to in the webinar today, and that's ADPKD, or autosomal dominant PKD. Autosomal, in other words, it doesn't sit within our other sex chromosomes that we inherit. It just sits in the other many chromosomes that we have, and it has a dominant pattern of inheritance, which I will describe. And it's polycystic kidney disease. There is another form, ARPKD, the recessive form of PKD. We're not going to be talking about this. This is a form usually seen in very early childhood. There's typically a very different pattern of kidney involvement and quite profuse liver disease. So we'll focus on ADPKD, and I'll probably slip between the terminology calling it ADPKD or just PKD. So autosomal dominant means that we only need one copy of the altered gene to get the condition. So you can see here that the father is affected with the condition. You'll see here it's got that little kind of white blob there sitting within the chromosome, indicating an altered gene that brings about the disease state, and a copy comes from dad, a copy comes from mum, and you can see here 4 children. There's a sort of 50-50 chance of inheriting the affected gene and thereby manifesting the condition. So that's autosomal dominant. Okay, and I say this with a degree of simplicity and confidence, as I'm aware that I'm being followed by a card-carrying geneticist, so I can duck out of the really complicated genetics questions. So the prevalence of ADPKD in a number of population studies has been described anywhere between 1 in 400 to 1 in 1,000 people. And there are a number of changes that have been described in the PKD genes that bring about the condition. There are 2 main gene forms, PKD1 and PKD2. The commonest is PKD1. Okay, which accounts for roughly 85% of cases, and the gene change for this form of PKD sits in chromosome 16. You don't need to remember this. This is the kind of clinically relevant bit. PKD2, the minority of cases, 15% of cases, and changes there sit in chromosome 4. And you may say, so what? Okay, so here's a doctor talking about complicated abbreviations. What does it mean? Well, people with PKD1 gene changes, the symptoms tend to develop at an earlier age, and on the whole, there is a faster progression of kidney dysfunction in people who've got PKD1 gene changes, or gene mutations is what the sort of formal letter will say. And if you look at the age, on average, at which populations have started dialysis, those with PKD1 gene changes typically have started a lot earlier than those with PKD2, which tends to be a sort of slower, milder form of the condition. Now, having said that, there are different manifestations of the same condition, both within a family pedigree. And also, if you look at one person with PKD as opposed to another completely different person with PKD, the condition can manifest very differently, progress at different rates, affect kidneys and liver slightly differently. And that's because the changes in the PKD genes are not always the same. Okay, so the location and the type of change within that gene may vary. If you look here at the bottom right, you don't need to make out the small print. It's just me trying to convince you that a number of different areas of change have been described. The way that this information is used to express the product, the protein, has varied. Okay, so there's a change in gene expression between people with the condition. And of course, there are other genes that interact on how we read this section of information, okay, modifier genes, which are inherited differently. So there is a spectrum of disease manifestation. Or basically put, that the way the condition behaves can vary both within family members and between people with the condition. Just to remind everyone what kidneys are, these sort of bean-shaped structures sitting here, the top part usually tucked behind the back of the rib cage, sitting near the back. They're about 10 to 12 centimeters in length. So on the whole, they are relatively small. You don't need to memorize this, but just to make the point that you've got here, you've got the outer functioning rind of the kidneys, the cortex that does a lot of the filtering of the blood. The blood flows into each of these millions and millions of kidney filters that we have. Blood is filtered, and then there's a whole load of post-processing that carries on in this long wiggly bit, the tubule. Okay, so there's a near and far tubule, a distal tubule here. And then by the time the flow of urine comes down here, you've got water regulation. It all pools into the central area and goes down here out of the kidney into the bladder. Okay, and my reason for showing you this is not to make you all expert kidney doctors, but just to give you a feel for where problems begin to arise when you've got changes in these PKD genes. So here we are back in the renal tubule and the sort of long wiggly post-processing bits. And the cells here in this tubule have got little frond-like extensions within the central bit, the lumen of the tubule. Okay, so the urine flows down that way, if you think of it flowing from left to right, and causes these little fronds to bend. Within these fronds, there are different structural proteins. And you can see here polycystin 1 and polycystin 2, okay, the gene products of PKD1 and PKD2. So this is where problems begin to arise. Okay, these proteins are involved in signaling this flow. Okay, so it's like the cell picks up a mechanical flow feeling from the flow of urine and then sends signals within the cell itself, causing changes in cell behavior. And what does that mean? Gory picture. It means that the kidneys develop multiple cysts within themselves. So within these tubules, the tubules, if you like, seal off and begin to fill up with fluid. And if you think of this happening extensively through the kidney tissue, you can see how you can go from having minuscule microscopic little cysts to bigger cysts, the cysts that are visible on CT, and then cysts that are visible on ultrasound and eventually palpable. Okay, where you've got significant cyst enlargement. And you can also conceive how by that process, you actually get a compression, if you like, of healthy kidney tissue around these cysts and how kidney function can decline over time. Okay, I'm going to, some questions are popping up, so I'm going to come to these. There's one about slowing kidney deterioration, which I'm going to come to at the end. There's a question here about family history. For someone with no family history of PKD, they've gone through, it looks like gone through a gene panel and no positive family member has been found, and there are certainly cases of mutations arising out of the blue or de novo, but I'll probably just defer that to my geneticist colleague to go in a little more detail. But basically, I'm just going to do the simple stuff. So how do people get diagnosed with PKD? Well, I feel like I'm sort of preaching to the converted here, really. But you will all be aware that in cases where there is a clear family history, routine screening is performed. Sometimes screening is offered and declined. Sometimes, certainly in my practice, I've had people come forward and say, look, do you think I should screen my kids? Do you think I should tell my brother or my sister to go and get screened because I've just been diagnosed with the condition? Sometimes PKD is found when there is workup for new onset high blood pressure, typically in people who are younger and in whom you wouldn't expect hypertension to kick off, particularly poorly controlled hypertension. GP does some blood tests, might see kidney function is off, and occasionally the GP might do blood tests and an ultrasound scan, and the ultrasound shows numerous cysts in both kidneys, and the PKD diagnosis is made. But sometimes it's just an incidental finding. Okay, sometimes scans done in pregnancy, or if someone has sustained trauma, particularly to the lower abdomen, and imaging is done, PKD can be discovered incidentally. Sometimes it's done on a scan to investigate recurrent blood in the urine, or in cases where someone's been having recurring kidney infection. When you do an ultrasound scan of someone with PKD, do you remember I said you can get all these multiple cysts? They can be of different size, and classically these are filled with fluid. So on ultrasound, fluid appears darker than the surrounding tissue. So I can probably convince you, if this is projecting well enough, you can see multiple cysts here of different sizes extending through what would otherwise be a normal sort of grayscale looking bean-shaped kidney. So it's important to figure out if there's a family history. I think this appeared in one of the questions. Imaging gives you a feel for how many kidney cysts there are and where do they lurk within the kidneys. And the age of the person in whom you first discover this is quite important. So age and the number of cysts is used when imaging is done to screen and make a diagnosis for PKD on imaging criteria. As regards family history, we know roughly about 25% of people who are diagnosed with ADPKD have no clear family history. I think like that question that was put on the Q&A. So this arises, as I said earlier, from a de novo, in other words, out of the blue gene change occurring in that individual that wasn't present in that individual's parents. Kidney cysts and diagnosis, this comes up quite a lot. In other words, how many cysts in the kidneys can one have that fits into the bounds of normality versus an excess of cysts indicating a diagnosis of PKD. So nephrologists and radiologists have got together to try to determine simple criteria whereby you can make that judgment. Most people end up getting an ultrasound scan. It's quick. It does not involve any radiation and is easily done. Okay. You also don't get the claustrophobia that you might do if you were to go into a CT or certainly an MRI scanner. CT and MRI, well, they've got better resolution, so they can look and pick up cysts that are smaller than can easily be seen on an ultrasound scan. Screening in children is contentious. I put this statement up. I think that is gradually varying actually as to whether you would screen in young children. You've got to appreciate that sometimes the cysts might not meet size criteria if you do the imaging when young. And so you can end up getting a false negative test, in other words, false reassurance that everything is okay, and then as the cysts get bigger, they're visible on ultrasound in later life. Some people are concerned about trying to screen and diagnosing a condition that a child might struggle to cope with, but maybe we're being a little paternalistic using 18 years, which is a sort of legal threshold for this condition, as increasingly we're aware that children in their teens probably able to appreciate and handle information better than we give them credit for. The number of cysts that you are allowed to have, as I said, varies with age. Again, you don't need to memorize this, only making the point that as we get older, we are allowed slightly more cysts in our kidneys that fit into normality. But you will also see that if there is a positive, if there is a family history, so family history of PKD1 versus someone appearing out of the blue, actually the number of permissible cysts in these criteria varies a little bit. I'm going to just quickly scan through the questions before carrying on. What exactly is a cyst? A cyst is a fluid-filled structure. Okay, it's roughly circular fluid-filled structure. Someone's asked a question about liver cysts and whether these are going to cause problems. Okay, and Susan, you want to answer that question live, so I'm going to leave that to you. Someone asking about whether they may possibly have PKD1, dad diagnosed with PKD2 and starting dialysis at the age of 74. By my understanding, it is unlikely that you will have a different gene change if your dad's been tested and found to have PKD2. And there's a question here for the geneticist, so I might leave that out. If a parent diagnosed with PKD because of out-of-the-blue mutation and no family history, can it then be inherited by that parent's children? My understanding is yes, it can, because of course it is in the parent. The difficulty sometimes is finding out what that mutation is, because you've got to go in with search tools looking for specific gene changes. But again, I might defer that to the geneticist. There's quite a lot of work going on for my next speaker. So what does PKD do? All right, and I'm going to talk in simple terms because I'm a kidney doctor. So the kidney complications of PKD, well, I alluded to this, a worsening of kidney function. So as the kidney cysts enlarge, you tend to see a reduction in kidney function. So the blood tests can look progressively worse. The GFR, which is a reflection of what the blood test result is, it's a reflection of kidney function, can decline over years. Okay, and what I said there about the relationship between cyst size and quantity and GFR was pretty much what they looked at in the tolvaptan trials. People can experience thirst and passing a lot of urine. So in some people with PKD, do you remember I said that the wiggly bits, the tubules, are also a little bit lower down, involved in the regulation of water, so water control, and this ability to produce concentrated urine when dehydrated can become impaired in people with PKD. Okay, if we didn't have this urine concentrating ability, we would all dehydrate. So our kidneys are on the whole extremely clever and try and reabsorb all this water that we would otherwise gleefully pass. And we do it in a controlled way. So when we're dehydrated, we want to absorb more of this filtered water, so we remain hydrated. Well, this mechanism can become a little impaired. And so actually some people can find that they pass more urine than normal and can get quite thirsty and prone to dehydration. The cysts themselves can cause a whole body of woe. People can get cyst infections. So you can get an infection held within the cyst. That infection can generate even pus and make people very unwell. So all the symptoms of an infection, severe pain. But we know that people with PKD are also predisposed to a higher frequency of urine infections. And this can be really quite a bane of some people's lives. Within the cysts, you can also get spontaneous bleeding. So from 1 minute to the next, you can get a hemorrhage into the cyst. That blood is very, very irritant and causes intense pain. Sometimes you see the blood being passed in the urine if that cyst ruptures, but sometimes it's just located within the cyst itself. There is a higher predilection to kidney stones, okay, and you can probably see if you look to the left and right of my central box here, actually if you dehydrate, you're also at much higher risk of developing kidney stones. If you've got lots of kidney stones lurking in there, you're more likely to get urine infection. So this can be a problem for some. Management of the kidney stone risk is really important, and really key to this is remaining well hydrated, passing good amounts of dilute urine. And pain. And I put pain a little bit out here. I've mentioned a number of painful events that can happen to people with PKD. But there is certainly a defined cohort of patients with PKD who suffer from severe and sometimes quite debilitating pain as the dominant feature of their condition. And certainly in the patients that I've seen who've required multidisciplinary care within a pain clinic, it's not even that the kidneys are horrendously enlarged with loads and loads of cysts. But there is something about the cysts and cyst size that does contribute to pain over and above enduring this symptom due to these other complications. A brief question here that I think I can quickly ask. What would blood in urine do to your blood results? It wouldn't do anything in particular at all. The only proviso is, of course, that one isn't having a significant hemorrhage from a cyst and becoming anemic. But there are people there who get intermittent bouts of visible blood in the urine. And in whom the kidney function per se doesn't show any change. There is no significant drop in hemoglobin. They don't become anemic as a result. Other problems that people with a diagnosis of PKD can get, and I know I've focused a lot on the kidney, but hypertension is extremely prevalent in people with PKD. Blood pressure requires good and assiduous management in everyone with PKD, with or without evident kidney dysfunction on the blood tests. I think most people are aware of a heightened risk of subarachnoid hemorrhage. This is a type of stroke bleed that can happen in people with PKD, and it's typically people with a strong family history of this condition, as well as PKD. So in this group of people who may have a family member who had a previous subarachnoid hemorrhage with PKD, and they've got PKD, in that group, screening for little aneurysms, little sort of gentle balloonings of the blood vessels that go to the head is recommended. The problems due to organ enlargement. So as you may expect, the enlargement of kidneys and liver with cysts can cause a number of problems in terms of body image, in terms of a strain on the back and mechanical back pain, but also in terms of a sense of fullness in the abdomen and the problems that they can cause, problems with mobility, problems with eating. So there are some people with significant liver cyst disease, and these liver cysts can compress the stomach, so actually it can't expand, and nutrition is a real problem. There is a higher risk of getting abdominal wall hernias, and it's been recognized there is an overall higher risk of developing diverticulitis. This is little outpouchings of the lower bowel, which can become inflamed, giving rise to that lower abdominal pain and a syndrome called diverticulitis. Someone mentioned livers and liver cysts. So liver involvement can happen. It is quite common to get liver cysts as well as kidney cysts in PKD1. There is in fact a discrete syndrome called polycystic liver disease, which has cysts developing only in the liver and not in the kidneys. By and large, the presence of numerous liver cysts in people with PKD does not impact on their liver function. That's sometimes a question that's raised. Liver dysfunction can happen, but there is extensive and severe liver involvement usually within that case. The problems that one experiences with liver cysts is similar to those cystic issues that I mentioned before. So in terms of symptoms, risk of infection, risk of spontaneous hemorrhage into a cyst. Someone has commented that they've had a polycystic liver and have been prescribed a statin for PKD, and I presume that is a statin to try to reduce cardiovascular risk, particularly when kidney function is lower. They've been prescribed a statin for polycystic kidney. However, is there a risk? Not to my knowledge, no. As I said, the liver is a fairly forgiving organ when it comes to its ability to carry out its tasks, and so can do what it needs to do, even if there is a fair amount of cystic liver disease. I'll carry on. So finishing off, the basics of management, I already mentioned blood pressure control. This is pretty much all you'll hear from a kidney doctor, I'm afraid. We're really into blood pressure control. Aim for a blood pressure of less than 130/80. And actually, I tend to go for a blood pressure of less than 120/75. So slightly tighter margins in people with PKD, with preferential use of an ACE inhibitor or angiotensin receptor blocker, or non-technical speak, those medicines that end in pril or sartan, either one or the other. There is some evidence to suggest that actually slightly tighter BP and with the use of ACE inhibitors in people with PKD is a little bit better in terms of protecting kidney function in the longer term. In other words, reducing the rate of kidney function decline, as well as obviously helping with cardiovascular risk. Lipid control, we've already had someone raising statin therapy. So control of serum lipids is recommended in people with impaired kidney function. That we see certainly greater rates of vascular disease occurring in people whose kidneys are not working within normal limits. I'm not aware of any conclusive data to suggest that statins themselves directly affect the progression of PKD. So it's done mainly as an adjunct to the management of renal impairment. High fluid intake is important. I write at least 3 liters per day. I probably would say at least 4 liters per day. That's actually can be quite a challenging volume to drink, as most of us, I think, would tend to drink less than this if we manage to get away with it. And this is before we even put tolvaptan into the mix. And tolvaptan is the one treatment for progressive PKD that has entered into the armamentarium over the last couple of years, and I think other than sort of alluding to its efficacy, I think it is really a triumph for studies in PKD. There are more agents being trialed in PKD to try to reduce the rate of kidney decline. And I will tail off this talk by just saying thank you to everyone who's taken part in these studies. You really are quite an exceptional population in driving research in this area, and there's still lots more work to be done. I'll stop there. Hopefully I'm to time. Is it common to have more cysts? I'm just going to answer, pick off a few more questions if that's all right, and then I'll stop. Why are you more prone to aneurysm with PKD? I'm not sure I know the mechanistic answer to this, but my understanding is it has something to do with the misprocessing of some of the structural components of the arterial wall. And so you're more prone to get particularly subarachnoid hemorrhage working its way through through a family tree.
Albert, you have plenty of time.
Ooh, okay. Let me work my way down then. So I try and
maybe a couple.
Yeah. So as I said, the genetic questions, if that's
there was
okay.
a question about what is a cyst that was came up earlier.
So so a cyst is simply a technical term to mean it's a fluid-filled structure. It's usually round, and that's all it is. So in this case, we're talking about cysts in the kidneys, formed with a sort of a lining of these tubular cells, isn't it, that get bigger, and they get bigger because they fill up with fluid, and you can get cysts in the kidneys and you know, a number of other organs as well.
Albert, there's somebody here who with an EGFR of 19 who is feeling very unwell, sick and nauseous, tired, and very anxious.
Yeah.
I mean, presumably this is something to be expected with an EGFR of 19.
Yeah. So if it's symptoms of kidney impairment, then yes, they tend to become more intense as kidney function declines, and this is because of the buildup of all the waste products that the kidneys would normally be filtering out. It's what doctors call fairly non-specific symptoms. In other words, they're general symptoms of feeling ugh. So fatigue. And it's usually fatigue in excess of any anemia people may be developing due to kidney impairment. So you can treat the anemia and they can still feel quite tired and drained, difficult to get motivated, concentration can become poor, tendency to sort of nod off, particularly in the afternoons. And then as kidney function gets a little worse, you tend to feel the cold a lot more. And then those symptoms of nausea can occur. Of course, we always need to think about other conditions that could be giving rise to some of these symptoms, because I think through our lives we can think about when we've experienced these symptoms, and there's all sorts of things that can also come along. So it's not always just the kidneys.
Yeah, there's somebody asking about pain, which we know is a common problem. And for those of you who have just joined us, we did have a talk on pain scheduled by Dr. Mike Lee, but unfortunately he's been taken ill. But Albert, I don't know whether you could offer an answer on this. This person's talking about sort of getting a lot of upper right abdominal pain, sort of around the rib cage. Is there any way of managing the pain other than painkillers?
Well, it's really difficult, isn't it? So the doctory response is just to give painkillers for it. The problem is that in some people with very, very intense pain, actually the amount and the intensity of painkillers that you can end up prescribing can itself be really quite debilitating. Other non-pharmacological ways, non-medicine ways of managing pain are also advocated. And you may recall I talked about multidisciplinary pain team. I think sometimes these resources are really important to try to maybe move away from using lots of opiates, lots of morphine-like painkillers. Simple exercises to improve back balance and mobility, Pilates, that enters into the mix. If someone's overweight, losing weight, that can help. Trying to do a little bit of regular exercise as possible. Sometimes TENS machines can be quite helpful as well for pain. So it can be a real problem. Interestingly, and this isn't in the licensing, but certainly in some cases of pain due to cysts and cyst-related pain, certainly in the tolvaptan trials, therapy with tolvaptan has been shown to cause an improvement in pain symptoms. So there's a number of ways of going about it. Scanning here, I noticed someone very sensibly, I was going to mention it, but they beat me to it in the chat about cysts in the pancreas with PKD1. Absolutely right. You can get numerous small pancreatic cysts in PKD1. I think we recognize that in imaging studies.
Yeah. There's a lady here concerned about her daughter who was diagnosed this week at the age of 14 following sort of back pain that they thought initially was to do with her doing gymnastics. I think really this lady's just sort of wondering what next, what's coming next.
Yeah, well, I suspect that she should be referred to a pediatric nephrologist, maybe, for a review of the imaging and a discussion. It sounds like I'm sort of ducking away from the question, but I'm not. I'm an adult nephrologist, not a pediatric nephrologist. But that would certainly be my move, because you know, we're saying we've got an ultrasound scan indicative of multiple kidney cysts in a girl who's 14 and who's I'm presuming mum, or also has a confirmed diagnosis of PKD, and so I think it's important to be seen by a specialist and to actually lay out exactly what to expect next and what the management plan would be.
Yeah. So somebody else here asked a question about do the sort of number and size of cysts equate to the speed of decline?
So we know that as the cyst burden, if I call it that, so number and size is kind of it, isn't it? The cyst burden increases, and therefore the overall size of the kidneys will increase, okay, because they're swelling up with enlarging cysts. Then kidney function declines. So the two tend to go in parallel. And I'd mentioned the tolvaptan studies. If you look at the TEMPO study in tolvaptan, you'll probably just focus on the graphs, and there's one graph there showing you rate of increase of kidneys when you look at how long they are on MRI, or actually their volume on MRI, how big they enlarge, and then you put that next to the kidney function graph, and so there is a proportional relationship. Yeah.
Albert, I apologize. I'm not sure if I think you may have already answered this, but it's just coming now. What exactly is the fluid inside a cyst?
Well, it's like serum. It's like that sort of watery component of blood. And does that answer the question? It's not kind of a thick, soupy thing normally. It's just like a sort of clear, watery fluid.
It's a good question.
We don't normally look at it in great detail.
It's said to be. Can you hear me?
Yep.
Yeah.
It's said to be an ultrafiltrate of the tubules. So effectively, what the urine will eventually become. So before that diagram of the loop of Henle, you can have them before the loop of Henle or after the loop of Henle. So they're basically the early parts of what the urine becomes, as it then gets progressively more and more concentrated as it passes down through the tubules. So it's early urine, I suppose.
Ah, okay. So it's just we've got time for a couple more questions. Does consuming animal protein increase the growth of the cysts, thereby causing faster decline of the kidney?
Not to my knowledge, no. I'm not aware of that as being a risk factor for it. I think there's this may allude to some initial concern and evidence about animal protein intake and the risk of progression of CKD, and thereby popularizing the use of protein-restricted diets in people with kidney impairment. But I'm not convinced there is robust evidence to say that actually being on a protein-restricted diet significantly affects your risk of CKD progression. Most of the data on those diets was in people with CKD stage 4, so to you and me a GFR of less than 30.
Okay. Just checking through if there's any more questions that we've missed.
If you drink 4 litres a day, wouldn't that put a strain on the kidney function? No, it doesn't. It doesn't. It's not that the kidneys kind of tire out a lot faster if you do that. That's a difficult one here. How often should you be tested for brain aneurysm if you have a family history of strokes? So the recommendation is as regards a family history of subarachnoid hemorrhage. This accounts for a minority of overall strokes, so it's important to understand what stroke type it was. Most people who experience a stroke due to a clot forming that goes off and blocks a blood vessel that feeds that section of brain, which dies off, and thereby giving you the phenomenon of stroke. So I think it's important to understand that. Lots of questions. High levels of urea in the blood, and what does this cause in terms of symptoms? Oh, I like this because this allows me to talk about an anecdote of how in the 50s there was an experiment where they were able to get medical students, because you were able to do that in those days, unfortunately, and give them high doses of urea. So you give them an infusion of urea such that you push their urea levels to around 50 or greater, and they checked to see what symptoms they got, and they actually got no symptoms at all. So there we go, anecdote shared.
That was a good one.
Blood pressure, an interesting one here about blood pressure and the difference between clinic blood pressures and home blood pressures. So someone being told by their doctor if their blood pressure is over 30, they should contact them. And in their experience, their blood pressure is higher in a hospital setting than it is at home when it's around 104/70. Increasingly in the medical literature, we've begun to appreciate that the one-off clinic readings can be remarkably misleading and tally less well with day-to-day blood pressure than readings taken outside of hospital. The outside of hospital readings have traditionally been done over the preceding 10, 20 years with those kind of cuffs that you keep wearing all the time and that keep going on and off in the day and in the night. And that was deemed to be a more accurate reflection of blood pressure. More recently, studies have been done to compare that method of the ambulatory cuff with someone just using their home blood pressure machine and taking readings. And probably the taking readings yourself at home with a machine that is within its validation range, in other words, you didn't get it 10 years ago and still relying on it to be accurate, let's say, doing those home readings tallies much better with what your real blood pressure is than just the standalone one-off clinic readings. So I tend to be very wary. If there is a big difference in blood pressure between what someone brings in and what I'm consistently reading in clinic, then I would check the machine. But more often than not, I see what the regular home readings are like, because usually blood pressure is lower at home. And what I don't want to do is to judge base my decision making and my recommendation for blood pressure lowering tablets on a blood pressure that's far too high. And then all I end up doing is causing that person to have low blood pressure and then faint and fall over at home.
How about this one? Does estrogen increase cyst development? This person's thinking about sort of the pill and sort of hormone replacement therapy.
Yeah, there was some concern about it. I think someone put a comment about women and polycystic liver disease and estrogen driving. Certainly, there's some evidence that estrogen may drive the formation of liver cysts. Do you know, I'm not aware that there is convincing evidence about an estrogen drive to kidney cysts and thereby changing the type of hormonal contraception that is used. But I say that with a bit of caution. So sorry, I couldn't answer that one. I don't know.
It's Anand Saggar. There's no evidence on the kidney. There was a lot of debate as to whether it was exacerbating the liver cysts in women because they get this massive polycystic livers in PKD, but there was no evidence that they tried estrogen blockers and various other treatments. It makes no difference. It's just something that we don't yet understand as to why women have a much higher predilection for massive liver disease compared to men in polycystic kidney disease.
Well, thank you.
Fantastic. One final question then. If the cyst growth process is slow or relatively slow in some people, why, this person wants to know, why not drain the cysts?
I think it's firstly, there are the cysts that we can see, and there are the cysts that we can't see, and one's only going to be able to drain those that one can see. Sounds a bit Rumsfeldian, but what I'm trying to indicate is that in terms of kidney function, well, that's going to be affected both by those that are visible on imaging and those that are not. And so by draining, all we're doing is removing fluid from those cysts that are big enough that you can see and safely get a needle into, because some of them would be too small to safely get a needle into. You need to, from what I've just said, get a needle into, you would appreciate that this is an invasive procedure. So whenever you take a needle and you put it into a body space, you run the risk of firstly causing inadvertent trauma along the track that needle is going to go down, including segments of the kidney. So you could end up snicking cystic lesions on the way in that might bleed. And then you run the risk also in so doing of seeding infection in there. So you can end up with a drained but infected area. As such, this isn't a strategy that we employ for all those reasons.
I have had some experience of doing this many years ago. And as you say, you can only pick off the cysts which are on the surface. We have done it for pain management when there's been a particularly large one and it's been more convincing that it relates to the pain. The trouble is they'll come straight back again. So you used to marsupialize them. So you used to open them out and then stitch the flaps back, but it didn't really work in reducing a lot of pain. There's far too many cysts. And also to stop them coming back, you have to sclerose them or sort of glue them down. And we did that once. They used to do it with alcohol, and we did that anecdotally to one poor chap who was a Muslim gentleman. He was very upset because it went into his bloodstream and he felt very tipsy. So that was embarrassing for us at the time. We didn't realize how much would get absorbed, and if you do it in other ways, it's very painful. In fact, the alcohol was painful too for him. So it's just not something we do anymore.
As I say, I agree. I tend to offer it on a selective basis for severe localized pain. And the relief is, as you say, often temporary.
Fantastic. I think we're now at just after 11. I think it's we're ready to move on to our next talk. So
thank you.
Dr. Powell, thank you once again for your time today. I think we should, and everybody, we show some appreciation for Dr. Powell, who is a fantastic support for the charity, speaking at many events, giving up lots and lots of time to attend these events. So many thanks.
Pleasure.
And so thank you. We'll see you soon.